This thematic review set out to identify common themes encountered at PMRT reviews across Cheshire and Merseyside. Cases reviewed were those involving stillbirths, neonatal cooling and neonatal deaths that had taken place over a 4-year period. A total of 42 cases were discussed, 8 cases of neonatal cooling, 32 perinatal deaths and 2 maternal deaths. The maternal deaths were not included in this review. The 32 perinatal deaths comprised of 25 antenatal stillbirths, 3 intrapartum stillbirths and 4 neonatal deaths. Of the stillbirths that took place before the onset of labour, 56% of these women had attended their maternity unit with a history of reduced fetal movements, which led to a diagnosis of fetal demise. Themes identified in the antenatal period were those surrounding initial risk assessment. These included missed opportunities for the prescribing of aspirin and/or failure to identify risk factors for small for gestational age. Lack of continuity of care, familiarity of guidelines and new or rotational staff were also cited as contributors. Regarding intrapartum cases, variations in CCG interpretation and differing thresholds of escalation contributed to delays in delivery. Situational awareness and geographical complexities were also cited. Examples included cross-site ambulance transfers and simultaneous emergencies occurring out of hours where consultants were required to attend from off-site. The COVID pandemic resulted in drastic changes to the organisation of maternity services. Maternal COVID infection causing placental insufficiency resulted in 3 of the perinatal deaths. Placental pathology unrelated to COVID, undetected SGA, maternal disease such as obstetric cholestasis or preeclampsia, and neonatal sepsis were also key contributors. Going forward, we have set up a regional task group to review workforce and training needs. To improve safety of intrapartum care, centralised CCG monitoring and standardised fetal monitoring competency assessments are being introduced across the region. Bereavement care will now follow the National Bereavement Care Pathway. Maternity triage units will use the Birmingham Symptom-Specific Obstetric Triage System to enable safer prioritisation of those requiring urgent care. Regarding the management of women attending with reduced fetal movements, a survey will be carried out to identify areas for improvement in care. We also aim to optimise our aspirin usage by developing a PGD for midwives. As well as this, a mandatory risk assessment shall take place at each visit, which will be re-evaluated intrapartum. Each trust should also be undertaking a review of their smoking cessation pathways to ensure opportunities for quitting are not missed.